This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon, and I practice in Midtown Manhattan, New York City, and in Wayne, New Jersey. My co-host is Dr. Marina Kurian, who is a minimally invasive and weight loss surgeon and practices in New York. And unfortunately, she cannot be here today, but we have a wonderful show on tap for you. We will be discussing cardiology and millennial health and disparities in healthcare. In a few minutes, we're going to welcome Dr. Modele Ogunniyi, who is a cardiologist and an associate professor of medicine and eminent/master physician at Emory Medicine and Grady Health in Atlanta, Georgia, and Dr. Jay-Sheree Allen, who is a family medicine physician and host of the Millennial Health Podcast. She is National Health Service Corps scholar, practicing in a critical access hospital in central Minnesota. Not only are they wonderful physicians, but they are passionate about education and dismantling the disparities in healthcare. We have a lot to talk with them about today. So please like and share and tag any of your friends who are interested in any of these subjects: cardiology, millennial health, and healthcare disparities. Please follow us on our channels, YouTube, Facebook, Twitter. We're also live on Shree's LinkedIn page. We have a podcast, and on Mondays from 2 to 3 p.m. Eastern Time, we are carried by WBAI 99.5 FM in New York and WBAI.org. So thank you for coming aboard. As usual, I'm going to start with a little quick news wrap up. Unfortunately, we have terrible news from the middle portion of the United States this weekend. We've been hit with severe thunderstorms that tore through at least 6 states, and those include Arkansas, Illinois, Kentucky, Mississippi, Missouri, and Tennessee. There are probably about 100 people who have died as a result of these terrible tornadoes that struck from Friday night onwards. There's hundreds of thousands of people without power, and the pictures of the devastation are just heartbreaking. So here at She's on Call, we send our love to all of the people who are affected by these tornadoes, and with hope for finding more people who are trapped underneath these buildings that have collapsed, and for these communities to rebuild. Additionally, COVID, unfortunately, in the United States is seeing a surge like we have not seen since November of 2020, so a year ago, and this is despite vaccinations. The hospitals continue to be overrun. The ICUs, or the intensive care units in New Jersey, reported 30% increase in COVID admissions. Nearly every single one of them is not vaccinated. Governor Kathy Hochul of New York State issued a state of emergency so that hospitals can react if they get overrun with very sick COVID patients, and that includes, unfortunately, canceling elective surgeries and elective admissions that people really need. As the map showed you earlier, just about every single county in the United States is essentially code red, has high or substantial rate of COVID transmission. So why are we still here? COVID started December of 2019, December 31st, 2019, and the shutdowns in America began in March of 2020. Well, we had Thanksgiving, so there were a lot of family get-togethers. Weather has gotten cold in a lot of the United States, so we have a lot more indoor dining and indoor gathering. And frankly, people are just tired of COVID. They're just, they're done. Unfortunately, COVID is not done with us. I took my daughter to a store to buy some shoes for some fancy things she went to. And oh my goodness, I guess in that store, COVID never happened because she and I were practically the only masked people in the store. Um, in addition, there is a new variant of COVID called Omicron, and Omicron is highly contagious. Just having had prior COVID infection does not give you protection. This was first identified by some careful public health work in South Africa and Botswana, so we owe a great debt of gratitude to these countries and their public health scientists, but it is actually everywhere in the world and throughout the United States. So why is Omicron so contagious? Well, this drawing shows the spike protein. So COVID is like a golf ball that has like these spikes coming out of it, right? So the spike proteins are the ones that attach and enter the cell. So if you look at the Delta variant of COVID, it only has 2 mutations in the spike protein that is different from the original COVID virus. The Omicron variant has 10 to 15 mutations there. So it is rapidly evolved to deflect our prior immunity from having the disease and even from getting 2 mRNA vaccines. But we are seeing the clear data where getting a booster shot of the mRNA vaccine really protects you from serious infection and severe infection from this new variant of COVID. So how does this happen? If too few people are vaccinated against a virus, those unvaccinated people, act as a breeding ground, as a place where the virus can mutate and change and get these sort of super strength to continue to infect other people. We are seeing too few vaccinations across the world, and we've talked about that previously on the show. And even though we're sending a lot of money and a lot of vaccines from wealthier nations, the US just announced another $400 million to help speed up global vaccination. We're also seeing that, you can't just manufacture nurses and public health providers and doctors and pharmacists, and people are taking care of local problems and local healthcare issues. So we really need to figure a way to sort of just get the vaccine to the people where it is needed. So what is the best way to not get COVID? Shocker. Wear a mask when you are with other people, especially indoors, who may or may not be vaccinated. Get vaccinated and get your booster. The United States Food and Drug Administration and the Centers for Disease Control just approved booster shots for 16 and 17-year-olds. So if you've had your mRNA vaccine set 6 months or more ago, so that would be June 12th or before, you can go ahead and schedule your booster shot now if you are 16 and older. If you had the Johnson & Johnson vaccine and that was 2 months ago or more, you can go ahead and get a booster. And Dr. Michelle Ah from Georgia, who is a friend and previous guest on She's on Call, suggests that we no longer call it fully vaccinated, which implies that you're completed or you're done with your course, but optimally vaccinated, which means that we can continue to follow the science. So we are live on Facebook, on YouTube, on Twitter, on Shree's LinkedIn. We Please like and share, tag your friends who are interested. We will be carried on WBAI 99.5 FM in New York and WBAI.org from 2 to 3 p.m. on Monday afternoon. And we have a podcast in case you just haven't gotten enough of She's on Call. Please go ahead and listen wherever you get your podcasts. We are so excited to meet our guests for today. It's our 58th show, and today we are going to be talking about cardiology and the health of millennials and healthcare disparities. Our guests are Dr. Modele Ogunniyi, who is a cardiologist, associate professor of medicine, and master or eminent physician at Emory Medicine and Grady Health in Atlanta, Georgia, and Dr. Jay-Sheree Allen, who is a family medicine physician and host of the Millennial Health Podcast, which is really terrific. I encourage you to take a listen and follow that. She is a National Health Services Corps scholar who is currently practicing in a critical access hospital in central Minnesota. Not only are they wonderful physicians, but they are passionate about education and about dismantling the disparities in healthcare. So welcome to the show, Modele and Jay-Sheree. We're so excited to have you here.
Thank you for having us.
Thank you. It's a pleasure.
So I loved meeting you just briefly before the show went on. You know, I'm a fan of both of you on Twitter and Jay-Sheree on your podcast. So I wanted to divide up today's show into 3 segments. I think first let's talk a little bit of hardcore medicine. Then let's talk about how you got to where you got, because I love your journeys. And then let's talk about disparities in healthcare, because they really do affect all of us. So, Modele, let's talk about heart disease. So, heart disease affects a huge percentage of the population. Over 30 million adults in the US have diagnosed heart disease, and it remains a leading cause of death in all populations. And some of the risks are listed here on this graphic: hypertension, high cholesterol, diabetes, depression, and obesity, as well as smoking, eating poorly, not exercising, and drinking too much alcohol. So can you break that down for us? And what is too much? What can we do to minimize our risk of needing you?
Thank you. Thank you for that question. And it's an honor to be on this show. As you summarized very beautifully, we all know that heart disease is the leading cause of death all over the world and even in America. So, what are the risk factors? You already listed them. But I'd like to go a step further and say that when we think about risk factors, those are attributes that a person possesses that puts them at risk for developing a disease. And when we think about heart disease, we can think about modifiable and non-modifiable causes. And most of the heart disease we see are due to modifiable causes. So just to dismiss the non-modifiable causes, there are things like age. We all know that heart disease increases with age. Family history would be one of that. If a first degree relative for a woman has heart disease at the age of 55, then they're at risk for men 55, and for women 65, then they're at risk for heart disease as well. Genetics also plays a role. But let's focus on modifiable risk factors, because that is what we can do something about. We can talk about hypertension, which is high blood pressure, known as the silent killer, which affects about 45% of the US population, and it affects about 33% globally. So we need to focus on controlling our blood pressure. My advice would be, you will not know what your blood pressure is until you measure it. So you need to make sure you know what the numbers are when you see your primary care physician. We also talked about diabetes. Diabetes also is a risk factor for heart disease. So what I'll say in general is that make sure you have an annual visit with your primary care doctor and you know your numbers. What is your blood pressure? What is your cholesterol level? What is your blood sugar? And then talking about the lifestyle habits that we can all do better. Stop smoking, cut down on your alcohol intake, get active. And like you asked, 30 minutes of moderate physical activity. And how I like to describe that is anything that increases your heart rate or makes you sweat. It could be brisk walking, it's not necessarily going to the gym, but anything that increases your heart rate and makes you sweat. 30 minutes on at least 5 days a week. Modify your diet. We talk about a heart healthy diet, a diet that is rich in fruits and vegetables. Avoid fried foods. Make sure you bake your foods, broil your foods. And those are kind of the things we've talked about diet, we've talked about getting active, stop smoking, and cut down on your alcohol intake. So I'll just stop there, and I know we'll have a lot of discussion.
So I wonder, I think, men and women are different. Our metabolisms are different. Our bodies are different. What is the sort of concrete, what is too much alcohol? What is too little exercise for a woman and a man?
I think in terms of exercise, I'm not aware that we have different, I guess, regulations or different recommendations for men and women. The guideline says 30 minutes of moderate exercise at least 5 times a day. For men and women, there are differences in the alcohol intake, and now I'm blacking out on the exact recommendations, but I'll kind of look that up as we talk. In terms of like the alcohol intake, I think it's like 1 glass, with dinner, but the exact like meals, I will give that to you now.
Okay, I think you're right. I think your advice of if you don't check your blood pressure, you can't quite know if it's elevated, right? If you don't think about what you're putting into your body, it's holiday time, right? So people are getting together, and I think Jay-Sheree, we talk a lot about getting together when you're standing and you're sort of the past hors d'oeuvres and the cocktails. You end up eating and drinking much more than you might normally do. What kind of advice do you give your patients about that?
To be mindful of how much we're consuming during the holidays. Holidays happen but so often, right? So I tell patients, you do need to enjoy your life. Please enjoy your time with your friends and your family. But this isn't a daily habit. The issue is, I need for you to have a healthy lifestyle and good routines. So if we break that for Thanksgiving and for Christmas and maybe 2 holidays in the summer, that's a very different story. What really counts is our daily activities, the routines and those habits. But specifically for the holidays, I tell patients, enjoy the pie, but maybe say no to the second, third, and fourth slice of the pie, right? So still try it, have a good time, but be mindful of how many times you're going back to the table.
I love that, especially that fourth piece. The fourth piece gets you, really. The fourth slice of pie. Ellen Austin is watching and asks us to really please define moderate exercise. So I know, Modele, you said something that makes you sweat. So, I walk very briskly from one place to another in Manhattan. Is that enough, or should it be much more of a targeted heart rate, for example?
So that's a very good question. Thank you for that question. I think that when we talk about moderate exercise, I think I usually tell my patients, because we have to think about when I look at giving patients recommendations, I look at in the context of where they are. So do they have access to, most of my patients, because I work in a safety net hospital, do not have access to gyms or access to fitness facilities. Some of them don't even have walking paths in their neighborhood. So that's why I came up with a phrase like, make sure it is brisk walking that increases your heart rate. So for example, you're taking like brisk steps for 30 minutes or more. And even if you're doing leisurely walk, you could go for like an hour, and that increases your heart rate as well. We talk about exercises that you can do in the home, like jumping jacks. We talk about exercises that you can do. But some patients tell me, when I say moderate exercise, they tell me, I'm on my feet all day at work, or I go to the grocery store and I walk. That is not what we mean by moderate exercise.
I like that, especially if you're snacking as you're
Yeah.
walking along in like at Costco where they have samples everywhere, or they used to before COVID.
And I wanted
Jay,
to quickly, sorry, I wanted to quickly
sure.
put in the alcohol. So for women, it is 1 drink per day, and for men, 2 drinks per day. That is what we describe as alcohol. That is what is reasonable alcohol consumption. The
And just
preference is no drink at all.
and to clarify, one drink is one beer, one glass of
Right.
wine, or one mixed drink. So they
Yes.
actually have
Yes.
similar alcohol content.
Yes.
You can't
Yes.
say, "Oh, I just had a beer, now I'm going to have my whiskey sour," right?
Yes. Yes.
Thank you so much. I appreciate you the instant fact checking. Jay-Sheree,
Yes.
you have devoted your sort of target to millennials and their health, which is very interesting, right? So this is a group. So I had to look up what were millennials. So millennials are currently between the ages of 25 and 40.
Yes.
And so these guys were born in 81 to 95. And that's so the baby boomers, then the Gen X, then the Gen Y got called millennials, and then the Gen Z are currently younger people. So I looked at a couple of surveys on millennial health, and most of them say that they have good or excellent health, but remarkably, and I found this shocking, 68% actually have a doctor, which means that they are better at being young than my generation was. Because until I got pregnant, I didn't get a doctor. Compared to Generation X, however, which were born 65 to 80, millennials actually have more health issues, including cardiovascular disease, endocrine issues, including diabetes. And remarkably, their health starts deteriorating at the age of 27. So can you talk to us about this sort of thing, that it's a new concept for physicians, right?
Yes, it absolutely is. So, I loved when Modele was talking earlier about some of those risk factors. So, I'm a primary care physician. So, I'm the doc that asks those questions and I get those sorts of answers. And that's actually what drove me to caring so much about my generation. I'm a millennial. And it's because I really wanted to get to us before the burden of chronic disease had a chance to set in. That's why I'm inspired to work with millennials. We don't have the heart attacks and the strokes yet, but if we can modify these risk factors, like Modele was talking earlier, we can actually change our health outcomes. And it was quite shocking for me to learn that at this point in our lives, we are actually as a group, less healthy than Gen Xers were at the same point in their lives. And so we are at a critical point for millennials where we need to change something, and we need to change something fast.
I really appreciate that. So, I looked up sort of the key health condition, because I'm like, what is this girl doing? Millennial health? Like, what does that mean? And I thought, okay, maybe binge drinking, right? Whatever young people do, says the old lady. But actually, the top 10 health conditions of millennials are worsening every couple of years. It's not like we have to wait a decade or two for these to worsen. And they are, I'm just going to list them for those of us listening without the visual, from top number 1 to number 10: major depression, substance and alcohol use disorder, hypertension, hyperactivity, psychotic conditions, inflammatory bowel disease, which is usually Crohn's disease or ulcerative colitis, high cholesterol, right? And you talked about that, tobacco use disorder, and type 2 diabetes. And these are really remarkably increased over time. So how do they intervene? How do we make those statistics from getting worse to getting better?
It was mentioned earlier, you need a relationship with a primary care physician. You need that annual exam. And it doesn't have to be annual, as in every single year, but you need to know what your numbers are, right? If you don't measure your blood pressure, you won't know what your blood pressure is and if we need to do something about it or not. It's a good idea to have a baseline of what's your cholesterol like, what is your fasting glucose or your hemoglobin A1C, what do you score on a PHQ-9? Like, those are really good things to have a handle on. And the way to access that information is a visit with your primary care physician. So that's where I'd suggest we start if we want to close this gap. You have to know what your numbers are before we can do anything about them.
So we have people watching from all over, and I really want to appreciate Eileen Chandler is watching, Sujit Mehar is watching, Miriam Berkeley is watching, Minnie Gopal is watching, Rie Bronander is watching, and I know Minnie and Rie have kids in the millennial category. So, I'm guys, alert your sons to tune in and at the very least listen to the podcast because Jay-Sheree really covers subjects in great detail there. We saw there that, I pulled out sort of Iowa as sort of this, mid-America sort of central thing. And modally, we saw hypertension affects 6 to 8% of millennials. And I don't think after many people leave their pediatrician office that they actually get their blood pressure checked. You just published a really, really good paper. Congratulations. Looking at all sorts of effects that cause hypertension. And we have the graphic up here if you guys want to take a screen grab. But Modele, can you talk to this a little bit?
Yeah, thank you. That's an excellent question. I mean, high blood pressure, like we have emphasized, is the silent killer. And even among teens and millennials, we are beginning to see high blood pressure. Now, the difference in this young age group versus older people is that older people tend to have what we call essential or primary hypertension. So hypertension that is not due to anything, but is as a result of either family history or age. But if, as physicians and as Sheree mentioned, if we come across younger people with high blood pressure, we begin to think about secondary hypertension. So is this elevated blood pressure due to something? Is it due to thyroid disease? Is it due to adrenal disease? Is it due to some endocrine disorder? Is there something we need to work up? And like we've emphasized during this show, if a blood pressure is never measured, you will not know what it is until the target complications develop. And we all know that racial and ethnic minorities bear a high rate of complications. So they develop hypertension at an earlier age. And because it goes unrecognized, they have a high burden of target organ damage. So what does untreated hypertension leads to? It affects all systems of the body. It can lead to strokes, which is affecting the brain. It can lead to aneurysms, which are ruptured blood vessels. It can lead to heart attacks. It can lead to heart failure, which is a weak heart. It can lead to kidney disease, and people end up being on dialysis. It is a multi-system disease that affects every organ of the body. So I think that, like Sheree mentioned, everyone on this call needs to have their blood pressure measured at least once. And as you grow older, that becomes part of your annual visits with your primary care provider.
And I will put in a little plug for ENT because we actually see higher rates of hearing loss and dizziness with untreated high blood pressure.
Yes.
So high blood pressure means that your arteries are being affected, and when they're being affected, they are not bringing oxygen as well as they could be to all of your tissues, right? I think that's sort of the simplest way to look at it. We have people watching from Spring, Texas, BC.
That's my mom.
That's your mom. That's your grandma. Hi, grandma. We're so excited that you're watching. We love your granddaughter.
It's my mom. My mom.
Your mom, your mom, just calling herself grandma, which is awesome. And Ariaga is watching from New Hyde Park. I have a lot of women patients who come in, and we measure their blood pressure. So even if you go to a non-primary care doctor, one of the things that we do is we measure your blood pressure, and we should be counseling you on it if it's abnormal. And they say, oh my God, my blood pressure was always 90 or 100 over 60 or 70, and today you got it as X. So what happens in particular to women as they get older in terms of their blood pressure? And older doesn't, as Jay-Sheree says, doesn't mean 60. It actually means in their sort of more fertile years. So I'm going to start with you, Modele, and then go to Jay-Sheree. So what affects their healthcare outcomes for women?
So for women, I think there are no differences in the outcomes or the complications, but one area that has really risen to the top is hypertensive disorders of pregnancy. So we know that if women develop high blood pressure in pregnancy, or they have chronic hypertension, or during pregnancy they develop what we call preeclampsia, which is elevated blood pressure with protein in the urine, elevated liver enzymes, they are 2 to 3 times at risk for developing future cardiovascular disease. So I think that in terms, and we know that a lot of attention has been placed on maternal mortality, but guess what? The reason for the high maternal mortality, especially among racial and ethnic minorities, is because of the adverse pregnancy outcomes, which include outcomes from hypertensive disorders of pregnancy. So I think that when we think about women, that's one thing to think about. There was also a recent publication that showed that women at lower blood pressure, so like blood pressures about 110 to 120, actually have an elevated risk of developing heart failure, heart attacks, and stroke compared to men. So for men, when they looked at women versus men, at 160, the risk increases for men, but for women was actually between 120 and 129. So those are kind of the sex differences that we see with blood pressure in terms of women. And also because women tend to be caregivers. So women tend to delay seeking care. They are taking care of their children, their older family members, and they tend to delay care, such that when they present, they're already developing some of these complications that we mentioned about blood pressure, that result from blood pressure.
Thank you. That's really interesting. So our target as women is 120 to 129 for that top number, that systolic number. The diastolic remains the same, right? We really are targeting 70 to 80?
Yes, we want the diastolic. Optimal blood pressure is blood pressure less than 120. The systolic blood pressure less or equal to 120, and the bottom number less or equal to 80.
And Jay-Sheree, where do we stand with millennials kind of knowing about this and about other health issues that can affect them?
So there needs to be more education about this. Unfortunately, there's a prevailing thought of, I'm too young for those problems, because we see the heart attacks and the strokes happening in our grandparents, or, depending on the age of our parents, in our parents. But we feel I'm too young for that to happen. That won't happen to me. But what we're not understanding is, a heart attack doesn't just happen at 70 out of the blue. There are risk factors that are building up, and we're leading up to that eventual outcome. And so now, in your time as a millennial, is when we can make some of those changes. One of the other things to add, and I can even add a personal example here to build off of what Modele just described. I'm a new mom. I just had my first child 2 months ago, and I was so hyper aware of, my being a Black woman, having a high stress job as a physician, especially in this pandemic. I have family history of diabetes, lost my grandmother and my father's sister, my aunt, to heart disease before 65. So I was so aware of, I need to try to eat as well as I can, take a little walk when I'm at work. It was just so exhausting to do it after work, but I tried to get a little walk every day. And, I followed up with all of my prenatal appointments, made sure my blood pressure, my blood sugar were all good. And I made it through all of those hurdles, had my baby. I was home for 3 days and then noticed that my legs started getting swollen. And when I would talk about it, I'm like, oh, you're doing too much. You're on your feet too much. You're standing too much. Then I developed like a really bad headache. It's like, oh, you just had a baby, you have a newborn. You're not getting a lot of sleep. But, thankfully, my husband was working as an EMT and had a blood pressure cuff at home. And we were able to check my blood pressure. And it was like, 160s, 170s. And I had never seen blood pressures like that before. Ended up getting hospitalized for postpartum preeclampsia. So even just little things like that, as Modele was mentioning with maternal related hypertensive issues, you may think you're through the pregnancy, so you're out of the woods, but it's not that way at all. And how many people would know that, it's after the baby that now I'm getting blood pressure issues. So that's happening to millennials because we're the ones having children at this age.
That's really, first of all, I'm so grateful that you're better. And I've seen pictures of your beautiful family, and I'm so happy that you had the presence of mind to listen to your body, right? Women are being told, finally, listen to your body and go and ask and just get things checked out, which I think Modele is right. We're so busy taking care of everybody else. There's not even a penny left at the end of the day for us. I think there's a concept of that fourth trimester, where you have these 3 trimesters when you're actually pregnant, and then you have the baby, and big fluid shifts, big things are happening to your body. 3 months, 4 months, 6 months after the baby is born. So I think chalking it up to, oh, you're tired, oh, you're this, oh, you're that, the baby's, oh my God, if you're not doing well, tell your doctor and bring it to their attention. And we've obviously all heard about the story of Serena Williams, who did try to bring it to her doctor's attention. And even she, the GOAT, the greatest of all time, had trouble convincing doctors that she was not feeling well. So be a pain, because it's your family is worth it. I think Modele, we flashed up that slide that had a lot of information about women's health and the disparities that affect women's healthcare outcomes, and we've put it back up. And if you guys take a screen grab, it's really this is from an article that really looked at so many things. Do you mind talking about this just a little bit more?
Yes, thank you so much. This was an article that we published recently out of the cardiovascular disease in women of the American College of Cardiology. So I think that as someone who has a public health focus, I not only look at my patient, but I look at my patient in the context of the environment. And most of us are familiar with the term social determinants of health, which basically means the conditions where people live, grow, work, and pray. So the environment where they find themselves. And all this contributes to how women fare in terms of their cardiovascular disease. So what access do they have to education? What access do they have to support? We talk about maternity leave. America is the only country that doesn't have a maternity leave policy. In the United Kingdom, where where my sister lives, they have access to paid a 6-month leave, and if they want, they can even take up to a year. So there are unique issues that women face that we need to address to reduce this disparity. I'll be remiss if I don't talk about racism and discrimination. So we as physicians, we're quick to judge patients, to say they're eating unhealthy, they're not exercising, they're not doing this. But it has actually been studied that some of these things might be discrimination coping behaviors. So Women who are chronically exposed to racism and discrimination have an elevated risk of developing high blood pressure, and that risk is more pronounced even for Hispanic and Black women. So I think that on a policy level, on a healthcare system level, on an individual provider level, when we see our patients, we should incorporate assessing social determinants of health. So do they have access to prescriptions, to education? Do they have access to insurance? We all talk about Medicaid expansion. That is very, very important, especially for postpartum women. I live in a state that hasn't expanded Medicaid yet. I hope that will happen. But all that is really important, especially in that fourth trimester that Sheree beautifully mentioned. So I think that these are the things we need to think about when we think about women's cardiovascular health. The things in their environment. Do they have access to walking paths? Do they have access to groceries that provide them with fresh fruits and vegetables? Can they afford it? Do they have childcare options? And even when we think about telemedicine, there's been a lot about telemedicine during this COVID period. We've got to think about people in the rural areas. What is the broadband access? So focusing on telemedicine, we've got to make sure that disparities in healthcare are not exacerbated, but rather we provide support so that we can reduce the high burden of cardiovascular disease.
I think you touched on so many important things there, including broadband access and a device that actually works, and being able to take time from your maybe 2 jobs or 3 jobs to actually even see the doctor for a telemedicine visit, let alone an in-person visit. I think public transportation is a big deal. I think there's so much that people like you with masters in public health, and we're going to get to that in a little bit, but people who understand public health have taught doctors who have originally been trained only in individual health. And I think until we focus on that, we're not going to get anywhere. I want to say Nivedita Chandrapa said postpartum blues. And yeah, there's postpartum blues, but there's postpartum ill health, whether it's physical health or mental health. And I think it's important. Dr. Adekola Ashaye is watching from Houston. The Curry family is watching from Atlanta. And because their name is Curry, I assume they're watching for me. Deirdre Gruen is watching. Vijay Sundaram is watching from Ottawa. Lori Vick and Trisha Turiano. Anna MT is watching. Thank you guys so much. I'm really enjoying this conversation. The Surgeon General just came out with it's very unusual when the Surgeon General issues a report on a single subject. It doesn't happen very often, but Dr. Vivek Murthy, and I must say, fellow Indian American and fellow Kannadiga, fellow Karnataka state origin like me, so I'm feeling very proud. He issued a rare public advisory warning about the mental health crisis among young people. And he was really talking about Gen Z. So he's really talking about the people who are now getting towards, between teens and 24, 25 years old. But these risk factors affect all of us, and certainly have spilled into the millennials who have not been able to finish their education the way they wanted during the pandemic, to get the jobs that they wanted during the pandemic. I know one of my sons has been working remotely. Well, two are working remotely, and one only met his coworkers 2 weeks ago after months and months on the job when they had their holiday party. So, Jay-Sheree, can you talk to us about how these mental health issues, particularly related to the pandemic, are affecting millennials?
Absolutely. As you mentioned, the Surgeon General spoke a little about the younger crowd, but it has spilled over. It has absolutely spilled over. One of the things that I think really impacted the mental health crisis that we're having in this pandemic, a lot of us, especially as millennials, we're trying to make some of these big shifts in our lives at the start of 2020. It was this like, new decade, new me, like, everyone going out there and really pursuing your big dreams. Like we had big goals for 2020. Like when the year started, it was, we thought everyone was going to make it that year. Right. And so you had a lot of people who took these really bold steps and then the world shut down. And so I think, the risk that a lot of people, the risk that a lot of people, put themselves out there and then had these dreams that deferred, really hit home quite hard. Another major issue is the isolation. We thrive sometimes in balance, they're introverts, they're extroverts, but, having just like conversations, getting a hug, being able to meet a friend for dinner or, to go and hang out with your colleagues. We weren't able to do those things safely for an extremely long time. And so even for people who had underlying issues before the pandemic, which is one of the things we talked about with the Surgeon General, they were worsened or exacerbated by this isolation. No one to check in on them, no one to see when things were getting worse. And then depending on where you lived, right? So if you were in central Minnesota, where I was, you could probably still make it outside safely for a walk. There's, enough space that you'd be fine. But if you're living, in an apartment, you don't have really good outdoor spaces. It was for a really long time very hard just being locked in the same building for such a long time. That really took a toll. And then the jobs, you talked about your son who's working remotely. It's so isolating to be in that space by yourself. If you think of the value of just your coffee break or going to the water cooler to refill your bottle, think of the little conversations you strike up. All of those things went away. And that really contributed to this mental health decline.
And, I was really surprised to read that mental health related cardiac ischemia. So that is the reduction in blood flow to the heart muscle itself. So you can get sort of like a twinge of ischemia, or you can get a full block and then you get a heart attack. But mental health related ischemia actually has worse outcome than physical health or physical stress related ischemia. So very briefly, can we talk about that, Modele?
Yes, that is a very, very important issue. And especially in this pandemic, we're beginning to see the impact of mental stress. There's an entity called Takotsubo syndrome. Takotsubo just means an octopus heart, which is commoner in women. So they present to the hospital with signs of having a heart attack on the EKG, on the blood work, and you take them to the cath lab and they have no blockage. But you look at the pictures of their heart, either by ultrasound or on the cardiac catheterization, and their heart kind of has this octopus shape, which we call stress-induced cardiomyopathy. It's commoner in women. So this is something that we really need to address. And even in my clinic, like Sheree mentioned before, we do what the PHQ assessment. We assess people for chronic depression because we know that people with chronic depression and anxiety do worse when they have heart disease as well. They are not able to develop coping mechanisms. They don't feel well enough to take their medications. So definitely this mental stress epidemic is affecting everyone, including the heart. And even in millennials, we're beginning to see younger and younger people who have mental health disorders, who are experiencing stress, present with heart disease. And the most important thing we see, as we've talked about today, is high blood pressure. Stress is linked to high blood pressure across the lifespan.
Thank you. Saida Garrett said, thank you for this information and thanks for all you do. Her husband happens to be an incredible jazz musician. So if you can get married to somebody who brings you joy in your home, I think we would all recommend.
Music is good.
It's really the way to go, is just marry like somebody fabulous, right? We are live on Facebook, on YouTube, on Twitter, on Shree's LinkedIn. Thank you, WBAI.org, for carrying us Mondays from 2 to 3 p.m. Listen to our podcast if you get a chance. I want our audience to meet the two of you a little bit more personally, and I think you've both shared a little bit. But let's just briefly meet you and get to a subject that's a little bit difficult at the end. So Jay-Sheree, you and I are basically soul sisters because we both went to City College in New York. I probably graduated from there before you were born, and yet I am sure you felt my footsteps as you walked in that beautiful campus. So let's talk about where you started and how you got to where you are.
Yes, so I was born in Jamaica, actually, on the island of Jamaica, Montego Bay. And my mother migrated to the United States when I was about 4 or 5 years old. So I stayed in Jamaica for a while, and then I joined her when I was 10. So I think we all have the New York connection on this call here. So grew up right outside of the Bronx in a town called Mount Vernon in New Rochelle. And so was there until I went to college, started at NYU, and then went to City College, where I was a Colin Powell Fellow. So that was really sad news to hear just recently of General Powell's passing. But that was absolutely instrumental. I think New York City is where I got my start in medicine. I did some work in the Bronx at Jacobi Hospital, and that's kind of where I first learned about healthcare disparities, which we're going to talk a little bit about now. And that drove me to applying to medical school. I went to Meharry Medical College in Nashville, Tennessee. It's one of the historically Black medical colleges. And caring for, the population in North Nashville, the underserved, underrepresented population in North Nashville. But I wanted to diversify my career a little bit. So I had the New York City Bronx experience. I had the HBCU experience. And so I wanted to get a better sense of, I'm family medicine, so primary care, the rural experience. So I ended up at the Mayo Clinic, and that's how I came to Minnesota.
I love it. And Modele, you were born in New York, and then your journey took you round and back.
Thank you. Yeah. So I was actually born in the Bronx. I don't sound like someone from the Bronx, but I was born in the Bronx when my dad, who is on this call as well, was doing his residency. So my dad is a primary care physician, like Sheree, and my mom is a pharmacist. But we went back to Nigeria when I was 3, and I went to medical school in Nigeria, but came back after medical school to do a master's in public health at Hopkins. And when I was a public health student, I took time to volunteer in the ER. And right there in Baltimore, I could see similarities between the poor health outcomes in Nigeria and the Black people we served in Baltimore. And that kind of started my interest in looking at disparities. And my project then was looking at hypertension in Black men. So after that, I did a 2-year preventive fellowship at the CDC, just looking at disparities in heart disease. And like Sheree, I did my residency in internal medicine at Morehouse School of Medicine, which is one of the HBCUs, and my cardiology at Vanderbilt in Nashville. So as part of my cardiology fellowship, I also worked at Meharry. So we're all connected. My continuity clinic was at Meharry Nashville General Hospital. So I think that, and now I'm currently at Emory in my clinical practice at Grady, which is the safety net hospital for Atlanta. So when I look at my career over the years, I think that my public health experience has made me a better clinician because it informs how I see my patient, not just, like I said, as an individual patient, but in the context of the social, cultural, economic, and political environment they find themselves.
Well, and I think your public health experience has informed those of us who were not smart enough to get an MPH to really try to understand and try to incorporate all that you and your fellow public health experts have taught us. So we have mentioned disparities in healthcare. We have mentioned negative determinants of healthcare outcomes. I wanted to share with our group, a slide looking at the racial makeup of the United States versus the racial makeup of healthcare providers. So you can see that 41% of the United States is Caucasian, 29% is Hispanic, 18% is African American, and 12% is Asian. But this is not at all reflected in the doctors that they see, and frankly, even in the administrators who run hospitals and health insurance companies. So we're seeing this disconnect between whom we serve and who we are to serve them. And you're seeing that only 5% of physicians are African American, only 4% of physicians are Hispanic. What is the concept of concordance? How does that help people get better? And maybe I'll start with Jay-Sheree.
Yes. So with that, and that's the next slide too that you're referring to, and there've been actually quite a few studies that have been published recently talking about that. So if you're talking about a black patient, them having a black physician, and so looking at whether or not their outcomes are different if they have a doctor who has a background that's similar to theirs. And we're finding that the answer is yes. There's also another really popular paper that came out recently looking at infants coming out of the hospital and the infant mortality rates. So we're trying to understand the reasons why patients who are of a certain ethnic background, if they see a doctor who also understands where they're coming from, their social determinants, who gets their housing situation, understands, their transportation issue, their family dynamics, how can that change the health outcomes?
So, we're seeing better outcomes when the healthcare providers have more diversity. And Harvard Business Review has a million articles that corporations do better with diversity. Everybody does better with diversity. Let's skip to who we let into medical school and who we let stay in training. And Modele, maybe you can talk to us about that.
Yeah, thank you. That's an important question, because to address this problem, we got to go to the pipeline development. So we know that 50% of medical students are female. But when we think about going down the pipeline, so from going from being a medical student to a resident to a fellow, the number decreases. So I'll talk about my specialty. Out of the 50% that goes into medical school, 42%, about 43% are internal medicine residents. But when we get into training to become a cardiologist, we only have about 13%. And when we look at the overall representation of cardiologists in America, only 3% are Black and 4.2% are Hispanics. So I think I want to leave us with a food for thought that we need to start at the pipeline. Go to high schools, talk to people about careers, STEM careers in medicine, in science, and from there, build that interest so that they are interested in science, they're exposed to science, and that is the way that we can increase the diverse career workforce in medicine. Not only, I speak about cardiology, but not only in cardiology. I'm sure you can talk about ENT, family practice. We really need to increase the diversity and increase the diversity as well in leadership. I think that in your field, even as a surgeon, there are really less women of color. So I think that it's a task for the society, it's a task for professional organizations as well.
Right. And then we had flashed up a thing where people are dismissed. So residents lose their position because they don't fit the other graphic where and it's really high numbers of people of color are dismissed, and it's a non-fit situation. And that is because we are laying the basis for this in perhaps not the correct way, or definitely not the correct way. We're also seeing that you have to be richer to get into medical school and to stay in medical school. And that's a real problem, because if we really want diversity, we want diversity of gender, we want diversity of background, we want diversity of rural versus urban. And then, Jay-Sheree, at the end of all of this, we get there, we're women, we did it. It turns out we make $2 million less over the course of our careers, accounting for same hours worked, same number of patients treated, etc. So there are, and this is just looking women versus men, and it is not looking at different non-white groups. So there's a lot your group really has to fix for us. We only have a few seconds left, so I would like to just get one takeaway from each of you, and I'll start with you, Jay-Sheree.
Oh, I would like to go back to our initial conversation about knowing your numbers. If you don't know what the blood pressure, the cholesterol, the fasting glucose looks like, we can't make any changes. So get in with your primary care physician and let's get to know those numbers.
Thank you. And Modele?
That was exactly what I was going to say, but I will leave you with the fact that you can do it. Be active, eat healthy, stop smoking, lose weight, and be responsible. And show yourself self-care. We've all been through a hard time, but remember that you are enough, you can do it, and you can live heart healthy.
Thank you so much. Our guests today were Dr. Jay-Sheree Allen, who's family medicine physician, host of the Millennial Health Podcast, practicing in a critical access hospital in central Minnesota. And Dr. Modele Ogunniyi is a cardiologist, associate professor of medicine, and master or eminent physician at Emory Medicine. Only 10% get that title, and Grady Health in Atlanta, Georgia. Thank you so much to our producers who make us look good every week. We really can't do it without you. Next week, we are back live on December 19th, and our last show of the year will be looking at healthcare in vulnerable populations. We'll meet Dr. Siobhan Westcott, who is an expert in Native American health, and Dr. Sapna Kudchatkar, who practices pediatric critical care. Stay safe, stay healthy, wear a mask, get your booster. See you next week.